Hi, my name's Katie. Today I want to talk about the evidence-based practice of group cohesion. My practicum agency is Recovery Center Missoula. I work with people who struggle with substance abuse disorder. We have 16 beds and 2 detox beds. We're an inpatient treatment program. We're actually considered a hospital. We're completely medically staffed. We have 2 doctors, many nurses, a nurse practitioner. Our average stay there is 25 days. As I said, we have 16 beds and 2 detox. We're the only detox beds in Missoula. We pride ourselves in our ability to deal with co-occurring and mental illness. Co-occurring is pretty much a given with substance abuse disorder. We've found that many people who have substance abuse disorder have other stuff going on. So we're trained to deal with trauma and how trauma affects people while they're in treatment. We use medication-assisted treatment. We use buprenorphine, also benzodiazepines to get people through alcohol withdrawals. Some people don't know this, but you can actually die from alcohol withdrawals, so we try to make that a little softer. The evidence-based practices that we actually use a lot. I feel like we use models, the strengths perspective, person and environment model. We use dialectical behavioral therapy, which is AKA mindfulness. It's actually the tenet of our treatment program. But when I was thinking about doing this project, I actually realized that group cohesion is really the gears that drive Recovery Center Missoula. That is not just in the clients, but it's also in the staff. So I want to talk today about group cohesion, and the article that I chose is called An Exploration of Cohesion and Recovery Outcomes in Addiction Treatment Groups. This study was done in Texas. It is a self-report study. They use scales, the Group Cohesion Scale Revised, the Multi-Dimensional Scale of Perceived Social Support, the General Self-Efficacy Scale, and the Coping Behaviors Inventory. So basically, they got 104 people, many people with drug addiction, many people were alcoholics, and they just asked them to self-report, and they asked these certain questions. And what they found, the results of this study is the greatest correlation was between self-efficacy and group cohesion. So the reason why I chose this evidence-based practice is because we use process group. We actually aren't allowed to, the staff aren't allowed to eat with the clients because their eating time is their time to build relationships in the treatment setting. And so what I, in my own life, have realized is that many addicts in recovery can't do it all alone. They need support. That's a given. Studies show that success in recovery is directly correlated with support. And so we take our clients to 5 12-step meetings a week. We have process groups. We do everything in groups. So everything, we have modules that we teach classes, and we teach skills, and we teach boundaries, and we teach how to deal with trauma, and we teach dialectical behavioral therapy. But we do that all. So all of those things are evidence-based practices, but we do those things with using group cohesion and the group dynamic as the tool. So group cohesion is kind of the boat for that. So the way that I can use this in my practice in the future is I can foster those relationships for my clients. I can build on the group dynamic, and I can help foster that growth through each other by letting groups run themselves. And I think that is the sign of the best counselors I've ever seen let groups run themselves. And that works. They can only understand each other. So thank you for listening.